Okay, so welcome everyone. It's delighted to have you back again on the Fatty Liver Foundation's More Tomorrows Live for Liver Health series. That's Learn, Inspire, and Value. It's been a tremendous past year or 2 years when we look at the developments in fatty liver disease, and understanding chronic disease and non-communicable disease. And today's topic is so topical and timely. It's SLD in the time of the Ozempic revolution and GLP treatment. And so we're just going to go through a brief overview before we get into a question and answer discussion set with our esteemed expert, Dr. Kenneth Cusi. Ken, welcome to the Fatty Liver family.
Thank you for having me. I've been following your good work for some time and flattered to be here today.
Excellent. Our first slide is our standard disclosures and disclaimers. And it's just very important that the information we give here is purely for education purposes. It's for sharing information, understanding case studies, best practices, etc. Your personalized management plan is best discussed with your primary care provider, your hepatologist, your specialist who's taking care of you. So this is not prescriptive in any way to offer you what you should do for your medical management, but it's about sharing information and educating you. And we once again very thankful to Madrigal for supporting this webinar series that we've been having with our patients. Next slide, please. So this is a slide I've been using for the past 2 years, and it talks about the gathering storm. And this is with the realization that there are millions of people, Americans, walking around with fat in their liver with some stage of fibrosis, and yet we don't have it diagnosed. They have a collection of chronic comorbidities which manifests in the liver and converges on the liver. By the time many people reach their diagnosis, they have quite advanced disease, so the cost implications for the healthcare system are much higher. We realized also that the public health system was not prepared when we're dealing with a multidisciplinary approach to care. So it's not just about medication, but lifestyle, behavior, diet, etc. And so that whole psychosocial and medical response that we have to deal with, and the health and community system. And for a long time, there hasn't been any treatment available for this. So very often, and we pick this up in the survey that we conduct, patients were told, well, you got to go home and watch what you eat. There's nothing we can do for you. And now things have changed. So this is a very important time that we've come in. Next slide, please. So much so, where I'm starting to think it's a storm no more. And this is just in the past year or two that things have certainly changed. And I think coming out of the starting blocks with resmetirom or Resdifra approval last year was the first time we had something to offer our patients in terms of treatment for fibrosis. In addition to that, we are starting to see really good models of multidisciplinary teams, hepatologists, primary care physicians, diabetologists, together with physiotherapists, occupational therapists, dietitians, etc. So this is a much more comprehensive offering for patients. The new nomenclature has offered a new level of awareness that we can do. NITs have come up over the past year, and so that's better for screening and also an opportunity for more accurate and precise diagnosis and staging. We have better management of the comorbid risks, and certainly the GLPs have been a huge factor in this. And I do have a big but on this, despite all the progress, is that are we taking care and mitigating the impact of things that are on a trajectory, or do we also need to go back to the source to say, how do we curb this? But at least we have important tools that we have at our disposal for our patient community now. Next slide, please. So our esteemed guest, Dr. Ken Cusi, is a professor of medicine at the Division of Endocrinology, Diabetes, and Metabolism in the Department of Medicine at the University of Florida. And I think he represents a rare breed of individuals that straddle many medical disciplines. And that's been really, really important. I, for one, have worked in the transdisciplinary context. And when you start looking at the intersection across disciplines, fields, and faculties, that's when the magic starts happening, where our efforts are not just additive, but they are exponential. And so that's the exciting time that we live in now. So with that, let me turn to Dr. Cusi. Ken, tell us about your areas of work, both clinical and research interests, and how you ended up being in the sweet spot at the intersection of all these disciplines.
Well, thank you, Neeraj. Again, thanks for having me. I love to share my journey, and that's the one. As you know, I'm an endocrinologist by training, and I've always been interested in clinical research in the areas of metabolic health, obesity, type 2 diabetes, and to be honest, I mean in early 2020s, I had a gastroenterologist who came to me and said, "Hey, we're seeing a lot of people with elevated liver enzymes, and they don't have anything that we could measure. They don't have any viral hepatitis, alcohol abuse, and others. So this must be NASH. And what should we do? I mean, should we give them metformin? They often have diabetes." And I began looking into this, and long and behold, we stumbled on something that endocrinologists, primary care, and even hepatologists had been distracted because of all the wave of viral hepatitis. It's been so successful to treat. So I think now the canons are now pointing towards MASH. And as you very well said, I mean, I've worked in this intersection for a while. My focus was to get a standardized guideline for management and referral of patients. And I think, as you said, and I say until 2020, should we do an ultrasound? Should we do FIB4? Who to screen? I was part of the ASLD 2012 guidance, and that hesitated to screen people with diabetes. But then this caught on. And I think since we put together 20 or 30 experts for the AGA guidance in 2021, I think that's where the FIB4 and optimizing diabetes and obesity management came into play.
That's excellent. And, you know, the old adage where if you're holding a hammer, everything looks like a nail. And the key thing is, because of the way the medical world had organized itself, it became very much a focus on on one's disciplinary perspective on how to manage patients. And for myself as a physician, working with the Fatty Liver Foundation, which is a patient advocacy group, all of a sudden we seen things from the patient perspective. And from the patient perspective, what our patients need are options. It's not one size fits all. It's not a single course of or protocol that we have to take, but based on where the patients are, we have to sort of design their sort of unique individualized journey. Does that make sense?
Oh, absolutely. To be honest, I like to say that the liver is like a mirror to your metabolic health. And again, if you have too much fat in the liver, sometimes even being lean, that says that maybe you just got the wrong genes. You may be insulin resistant, and then you would have to really focus on lifestyle changes, as you mentioned, and approaches that will get you back to get that metabolism back on track. So the patient's perspective and where they're coming from is critical to success, and sometimes doctors forget about that.
Absolutely. So could we get the next slide, and we'll just go through some of our framing slides. Okay, so with all these different perspectives, there was the consensus report that was developed. And you were very involved in this, right, Ken?
I was lucky to be the chair and to put together this wonderful team that we had with the American Diabetes Association.
And do you want to give us the gist of it? Like, what was this big consensus that developed, and we went through the consensus understanding of the change in nomenclature. So really important governance processes. But what was the outcome of this report?
Well, the outcome of this report was a culmination of an evolution, as you mentioned, on the diagnosis. So when in 2021, with Fasika Canwell, the American Gastroenterological Association came up with this first guidance, and that she was the first author, I was the corresponding author. We set up the stage, but we felt that that was getting more into the liver doctor realm and not to the primary care. Then the American Association of Clinical Endocrinologists, I was able to chair the first guidance for your primary care. So that's why I encourage patients to talk to the primary care, because they're getting now to do this initial liver health check. Then the ADA, that had not paid a lot of attention until 2019 to, at the time, MASLD, came up saying, well, be careful if you have elevated liver enzymes or fat in the liver. But then this evolved, and in 2023, we wrote the first recommendations that were aligned with ASLD and other scientific guidelines. And this consensus that we did it this year is an in-depth dive in the key aspects, as you can read there, for the care of people with prediabetes and diabetes, which are two of the big highest risk groups for steatohepatitis and cirrhosis. And it goes all from the need for more awareness, the pros and cons of the nomenclature change and areas of more research. And as you see in the right box, the need for interprofessional teams, because this is a journey, not a destination of success, a lifetime journey, the role of alcohol, liver health, and so forth. And we put together liver experts, obesity management experts, diabetes educators, nutritionists, endocrinologists. So it's a really nice team. And I'll tell you in 3 or 4 slides the key messages here.
Okay, let's dive into that. Let's go into the next slide.
Yeah, so we want to focus today on the GLP-1s, but I think to put them in the right context, I have 5 slides for this audience, and I'm going to be speaking largely for non-physicians or for primary cares. I know many of the hepatologists have been working on this and are very aware of this, but my interest as an endocrinologist has focused on the group which has the highest risk, people with prediabetes and especially type 2 diabetes. We have a work now that shows also people with type 1 diabetes with obesity have a similar risk to that of type 2 diabetes. And again, if you don't have diabetes, your risk if you have obesity is less, but close to that of diabetes. So on the left, you see that about 70, if I grab 10 patients coming to my clinic tomorrow and measure the liver fat with imaging, 7 or 8 will have too much fat in the liver. And of these, about half have that inflammation that we call steatohepatitis or MASH. Among those, our screening is to try to identify those who are on a path of fibrosis, as you see in the third group there, and significant fibrosis, what your liver doctor may say moderate to advanced fibrosis or at risk of cirrhosis MASH. There's a confusing soup of terms, but significant fibrosis might be the easiest one. And then a few of them will develop cirrhosis. So when you look at transplant lists, about half the people have type 2 diabetes and the vast majority obesity. The good news, as Neeraj mentioned, is weight loss by any means, GLP-1s, pioglitazone, and resmetirom, all are approaches that we can do to reverse the inflammation and halt or reverse the fibrosis. So with that, on the next slide, I want to show you something from our own experience. Here, this is preliminary data in almost 600 people we recruited at the University of Florida, coming completely unaware of whether they had too much fat in the liver or not. And if you see in the endocrinology clinic where I work, 22% have that. F2 is what the pathologist calls significant fibrosis, okay? And F3 is advanced fibrosis, so near cirrhosis or cirrhosis. So if you look at that 22% on the left, if we click once to focus on that, we will see that that 1 in 5 people with type 2 diabetes who's coming to an endocrinology clinic have a significant fibrosis. They're on a path to cirrhosis. If you go to internal medicine or family medicine clinics, a little bit lower, because typically endocrinologists see people who have long-standing and more difficult to control diabetes. But this is a number that I think is critical to see how big this problem is. So remember, if we can click again, Tiffany, we will see that this is the focus is people with diabetes and obesity. Next, please. And this is the guidance that we had with the ACE. If you look on the left and we click now, we will see that these are the 3 groups to remember. At the very top, I would have changed the slide now after I did it, and it would be type 2 diabetes. Then pre-diabetes are those who have their fasting glucose is slightly elevated, but not in the range of diabetes. And if they're obese, they're at higher risk. And then obesity with cardiometabolic risk factors. So if you know that you have obesity and you have hypertension, and say you have abnormal cholesterol or triglycerides, if you put 3 factors together, your chances of having steatosis is like 80%, and having fibrosis about 1 in 5. So you should check yourself with your primary care doctor. And then at the bottom, of course, incidental finding of steatosis or elevated liver enzyme above 30. So clicking again, we want to prevent cardiovascular disease, but again, above all, the next would be preventing cirrhosis. So if we click again, that's our target. And there is one tool that you would like to ask your doctor. Okay. So if we click that thing, that test is the FIB-4, which is an imperfect test, but you already have it in your electronic medical record, because it's composed of 4 factors that are very important for advancing liver disease and for fibrosis, which is age. As we age, we have a higher risk. If your liver enzymes are elevated, as we say, AST or ALT above 30, not 40 as in your lab reports, above 30. And then if your platelets go down, and you say, why platelet? Platelets are the little guys say that are in our blood that help with clotting and prevent the additional bleeding. But when you have very sick liver, there's an increase in the pressure of the circulation, a backup pressure that causes the platelets to be lost in the spleen, and their levels go down. So when platelet levels go down, your chances of severe fibrosis increase. Next, please. So to remember, this is the scheme now in 2025, which is basically the same across most medical societies. You want to ask your doctor, what is my FIB-4, doctor? And again, if it's equal or greater than 1.3, you will want to make sure that you have a second test. So if it's below 1.3, click, please. You will discuss with your primary care doctor. If you're overweight or have diabetes, you want to work on your lifestyle and maybe consider some medications. But if it's equal or greater than 1.3, you will want to have a transient elastography test, where you see there the liver stiffness measurement. We want it to be ideally below 6, but if it is equal or above 8, if we click again, we focus that we wanted you to see your liver doctor. So this simple message of high-risk groups, FIB-4, and referral when needed is what we are advocating by the ADA, ACE, ASLD, and all the liver and endocrine societies. Next, please. And this is the last slide. I have another slide about lifestyle and multidisciplinary teams that we can talk at the end. But this is a summary of what you need to know and discuss with your doctor. On the left, adoption of a healthy lifestyle, weight loss, optimal diabetes management, cardiovascular risk reduction. Take your statins. Actually, statins are good for the liver. Not bad, as we have been taught for decades. I mean, They have a lot of good things. And because if you have MASLD, you have higher cardiovascular risk, you should be on a statin. And again, consider metabolic surgery. Now, we created 3 levels of concern. One, when you have this metabolic associated steatotic liver disease without fibrosis, we call F0 or F1, very mild fibrosis, okay? In this group, we're going to focus on your management of obesity. And again, we prefer GLP-1s, say, basically, we can focus on obesity pharmacotherapy. If you have diabetes, you're going to use also a GLP-1 or a dual agonist like tirzepatide. Pioglitazone has shown to reverse steatohepatitis and occasionally fibrosis. And SGLT2 inhibitors that you might have maybe be taking if you have diabetes have shown in population-based studies to reduce the progression to cirrhosis and reduce fat. But we don't need to use specific MASH pharmacotherapy. If we click again now, we're going to focus on the group of greatest interest and where we begin to have available pharmacotherapy. So if you see your doctor, you have obesity or diabetes, and then the transient elastography test detects that you have moderate to advanced fibrosis, then you are going to continue choosing these agents. We don't have enough evidence for SGLT2 inhibitors, so we could not put it as an evidence-based approach, but would not be harmful. But we have like 6 randomized controlled trials with pioglitazone. We have a big study that was published this year with semaglutide, and the FDA approved it in August for the treatment of MASH. So we have now 2 MASH pharmacotherapies, resmetirom, as Neeraj mentioned, approved in February of 2024, and now semaglutide. And again, we'll talk later about the pros and cons and their eventual combination. And then cirrhosis. We don't want to get to this stage. Early stages are reversible, but now pay attention to here. We want to avoid the use. There's very little evidence for GLP-1s to reverse it. It may still be effective to lose weight or control your diabetes, but we don't have evidence that it reverses cirrhosis, say, just a small study. And neither drug, resmetirom or GLP-1, have been approved for people with cirrhosis. There are ongoing studies, however. And then decompensated cirrhosis, we do insulin. So with that, I think I'm going to hold. And then if we get into lifestyle, we can talk about that. But maybe we can do that right now. Just I want to highlight one thing. If we get to the next slide. There's one aspect. Many of you are very familiar with all of these things: weight loss, healthy eating. This is diabetes support and education. Physical activity. I wanted to highlight the alcohol in this slide because you should be very clear that guidelines for everybody for alcohol have changed. Any alcohol could be harmful, but particularly if you have moderate to advanced fibrosis, there's a very synergistic harm of alcohol in the setting of MASH, particularly if you have significant fibrosis. So try to avoid that at all costs. And I will stop here. We have one more slide about multidisciplinary teams. We can touch that at the end. So let's focus here on GLP-1s. Come on, let's start the pink question.
Absolutely. And Tiffany, we can go off slides now and just sort of have this conversation.
We'll get back to this, Tiffany, yeah.
Before we come to those concluding slides. So I want to home in on MASLD with F2, F3, because this is the zone of indication for our pharmacotherapy, and so what should the considerations be for patients who have been diagnosed with stage F2, F3 as they navigate their various risk factors, what's been approved, the duration with which it's approved, patient preferences, etc. So how do they start working with their primary care physician or specialist to customize their plan?
Well, that's a great question. And I want to instill hope in our patient. It's, as I like to say, there's never been a better time to have MASH than now in the history of mankind, right? From Homo sapiens, 200,000 years. In the last 2 years, we have two new options that have been proven. So I would say we're not going to talk today much of lifestyle, but as a diabetologist and metabolic health doctor, that's the cornerstone. We can't just, you know, we expect pharmacotherapy to do for us what our lifestyle doesn't. So with that on the side, let's focus on pharmacotherapy. So the reason why GLP-1s have been such a game changer is because they've done things we did not expect. We knew that losing weight was good. We didn't expect that it would change diabetes management so much. They have indications now for heart failure, indications for chronic kidney disease, and now the liver. So it is really important that I think doctors help patients help their doctors be proactive. Number one, as Neeraj said, may I have a moderate to advanced fibrosis? You will have no symptoms, so you need to ask your doctor. The second approach, once you know that you have this problem, is that you can know that this is reversible now. I mean, that inflammation can go away not only with lifestyle, but with the two pharmacotherapies we mentioned. If you have diabetes, you will choose agents that can improve your sugars, but also your liver. And these are well, of course, semaglutide because of the phase 3 data. Tirzepatide which has, we're not going to use commercial names unless you want, Neeraj, but I think we'll keep it on a scientific level. And then pioglitazone is $5 a month. And I am a big advocate because I've traveled the world giving talks. And the truth is, many Americans and most of the world can't afford the drugs that we have for MASH. So I think pioglitazone is the poor man's or is a drug, but it is shown to reverse inflammation and sometimes fibrosis. So I think that GLP-1s are now kind of a first line approach because they can do all these other things. But it is critical first to know where you stand and then see if after therapy you would need additional treatment. Because I think the future, as you suspect, Neeraj, is going to be combination therapy as we do for diabetes and hypertension.
So I think that makes a lot of sense when we look at the symptom complex or the collection of comorbidities that is quite typical of patients with MASLD MASH, namely the type 2 diabetes, the obesity, etc. But we also have an entire cohort of patients who don't necessarily have those comorbidities. The lean MASH patients, people with particular ethnic or cultural origins, etc. And would they consider what would be the difference with navigating their management plan?
Okay. So the vast majority will have comorbidities. And again, if you are listening and have MASH without obesity, you should know that in reality, even people that we call lean have visceral obesity. And this can still improve with GLP-1s. But again, in that sense, the bang for the buck of weight loss is going to be less and less. But you should know that physical activity can also help. And how? Because NASH in people or MASH in people without obesity or in the lower range of being overweight is always associated with insulin resistance. And there are two things that reverse insulin resistance: weight loss and physical activity. Okay, so that is an important thing. From a pharmacotherapy perspective, I think, again, GLP-1s could still help. In this stage, there will be a bigger role for resmetirom if you are lean. It doesn't cause significant weight loss, but as you know, It has a placebo-subtracted benefit of 20% on steatohepatitis and about 10-12% on fibrosis. So it'll be a good choice. The real challenge of, again, these medications, both GLP-1s and resmetirom, is cost. So the cost of GLP-1s is still expensive. I know that companies now have direct, again, since there are patients who may not know, they have a direct-to-patient programs, both for semaglutide and tirzepatide, in which the price is still in the $500 to $600 a month. But again, if you use it for obesity or for some other comorbidity, the cost for MASH is zero, right? I mean, Neeraj, I mean, you're using it for something else. For resmetirom, again, you would expect that you have steatohepatitis and fibrosis, and it will be covered by insurance. I don't know what your experience has been, Neeraj, with that. I mean, have you had a good experience with insurance companies accepting it?
Well, it depends which insurance, and you know, we've heard different stories from our patients. Yeah, our
Yeah.
patient
So,
community.
but again, if not, you should know that it is a drug that will cost $50,000 a year. So this is something that you need to work with your liver doctor and have a careful discussion with him on terms of what would be best for you.
Um, so So, what would a positive response be to these drugs? Because we talk about reversal of disease, but we also talk about halting progression of disease. And so, what what should patients expect when they get onto these courses of treatment?
Well, I mean, that's a very good question. I mean, number one, we are a little bit in a bind, I would say. We monitor liver enzymes that, in general, the bigger the drop, the better off the liver is. We follow fiber scans, again, which have limitations, but then we can also do MRE, so magnetic resonance elastography, which probably is the most accurate approach. Now, for the patients, I mean, we are in a good place now because even if you don't reverse the fibrosis, if you just can freeze the disease at pre-cirrhosis or early cirrhosis, you'll probably never die of liver disease or need a transplant. So the concept has to be not only reversal, but holding the disease, at least holding the line. And I see that a lot with the therapies for diabetes, obesity, and resmetirom. So I think if you are proactive as a patient, you are in a very good spot to never develop cirrhosis, I would say.
Um, I think that's a very positive note, and you know, it's interesting because there's more involvement of sociologists and psychologists in patient care and health nowadays, and very often they dealt with the lifestyle, the social determinants of health, the diet, exercise, etc., while doctors worked on the prescribing side. But there's a lovely synergistic effect, and the positive impacts from being on this sort of treatment is the type of boost that a lot of patients could benefit from to actually address the lifestyle thing. But one of the challenges that we see very often is that these these different components of patient care operate in parallel or in silos. And
Yeah.
how are we moving to that direction where we offering our patients as comprehensive a care package as possible?
Well, Neeraj, you're always doing these great questions, and you're a very smart and wise man, I can tell. But this is where we have doctors now are very busy, overworked, and being asked by their organization to see more and more patients, which leads to frustrations on both ends, patients and doctors. But I think that is changing. I mean, every guidance recognizes the importance of metabolic health, the importance of lifestyle, and the need to address all these issues. Now, my advice would be for the patients to be proactive. Demand to know what your liver health is. Demand to know what are the options. Demand this dialogue with them and among your primary care and your liver specialist to reach the best outcomes. I think if I have to do a 1, 2, 3 step, is number one, know what your liver health number is. Like I educate my people with diabetes, know what your A1C is, or know what your lipids are to prevent cardiovascular disease. I would encourage that you ask your doctor, what are my liver numbers? What is my FIB4? Should I do a FibroScan? Should I do a shear wave elastography test? Should I do an MRI? Again, probably your primary care doctor can say if your risk is low or high. Again, if you have diabetes, obesity, hypertension, and lipid problems, you probably do also have a liver problem. So I would really be very careful evaluating that. Second step is write down your questions when you see your doctor, okay? Because you're going to forget. And write down what your doctor tells you. Be proactive. I mean, you're going to get a lot more of that 20-minute visit, unfortunately, so short, if you write down your questions and write down the answers. And third, as I said, I mean, you should be very optimistic and proactive. And starting a GLP-1, to me, it's a natural approach if you have these comorbidities and liver disease. But remember that the numbers show that only 2 out of 3 fully respond to just a therapy. So you need to act those lifestyle changes. And if you stop the GLP-1, the chances are that you're going to go back to those cravings and regain a lot of the weight. So you need to be thinking long-term therapy. And then, as Neeraj said, know your numbers. Are my liver numbers improving? Should I repeat an imaging study? Should I add resmetirom or pioglitazone, or what should I do next? Again, remember, there are several diabetes medications that also help the liver, not only GLP-1s, but probably SGLT2s and pioglitazone. So lots of work. And I see lots of questions also, Neeraj.
Yeah, I want to encourage people to send their questions in, and you can look at the questions, right? You
Okay,
can
yeah.
see it on your screen. Yes, we will make the recordings available. On behalf of the Fatty Liver Foundation, what we will do is try and map out some of the approval and payment pathways that we're hearing from our patients, and it can get quite detailed. So I want to stop getting into that detail on the call here. But I do want to ask, from working on previous disease issues in the past, we always thought about, well, let's stagger how we use the tools and therapies we had. And yet for some disease profiles, we arrived at a conclusion where we said, no, hit hard and hit fast with everything you got, because that's how you change things. So looking into your crystal ball, seeing what the data is like, and you spoke about combination therapy, where do you think this field might go, and what would your wish for it be?
Well, I think we're clearly going to need combination therapy for the majority of people that have MASH. Now we have 2 drugs, but as you know, Neeraj, there are another dozen that are in phase 2 or phase 3, at least, many more, but let's say with a good chance of getting near approval or approval. So I think that thinking about the patients who are listening to us, I think that I think for the time being, GLP-1s are going to be your cornerstone. I don't think you should try another medication before them. And if you can't afford them, again, insist on lifestyle. Consider if bariatric surgery is good for you. I like a low dose pioglitazone because it's so cheap and will reverse steatohepatitis in about half the people. But their combination is going to be what we need, I don't know if I'm answering your question there.
Um, so I think there is an element of staggering, and we have to have our thresholds very clear on when we add, and what is a fair trial period on a particular medication to see what type of response we get before adding, etc. So still a lot more work to do in this area.
Yeah.
Um,
Yeah,
um,
I think so. Answering your question, I see where you're going to. How long should I wait for one drug before trying another? Well, the evidence that we have, which is limited, show that these studies are 12 to 18 months. So I guess that I would try one drug first. And the reason why not trying all at the same time are twofold. A, cost. And second, that you won't know which one is working for you if you get some benefit. Maybe one is not. So at this point, I think I would start with one drug. And again, I think GLP-1s for their number of other benefits and really as they treat diabetes and obesity, your treatment for MASH would be free, basically. That would be what I would use at least for 12 months as a monotherapy. You can add again, if you want to add SGLT2s for your diabetes or pioglitazone that's so cheap, I think that wouldn't be a problem. I think after that, or if you've been on the GLP-1 for a long time and now they diagnose that you have significant fibrosis, resmetirom would be what I would add if you've been at least for a year on a GLP-1. And again, this is a lot of people. You know, there are 30 million people with type 2 diabetes. If we consider that 15% at least have significant fibrosis, that's, you know, 5, 6 million people that we haven't treated yet. So it's a big number of people. So somebody asked there, what is the name of a liver specialist? If you tell your primary care you need a liver specialist, they will know. But answering your question is a hepatology from the liver is hepato and hepatologist or gastroenterologist. Okay, we can type that in there for that person. But at the time, we need to start with one and add another one. Again, if you have diabetes, you can add diabetes medications. And again, I'm not just choosing this or the ADA, this also being in the pharmacological treatment for type 2 diabetes. For the first time ever, Neeraj, the ADA added MASH as a subtype of diabetes that needs these specific therapies, you know, GLP-1, dual agonist, SGLT2, or pioglitazone.
So that's very helpful. But I would be remiss if I didn't address this question because it's been coming up quite a bit, and it's been interesting because some people have had an easier pathway with GLPs compared to resmetirom. Some people have been having a tough time with GLPs and getting them covered as well. So if a patient is sitting in front of you and you know, we have this evidence coming up, there are several options available, and then they look at you and then it becomes an issue of cost. What would you recommend, or what advice do you give them?
Well, my advice is that that to look at themselves also not in a siloed manner, and knowing that their liver is a reflection of their overall metabolic health. If they have fat in the liver, they're probably insulin resistant. You also need to think of secondary causes. We mentioned alcohol. Alcohol can also be a cause of that fat in the liver. I think also there's some literature that GLP-1s can reduce the cravings for sweets and alcohol. I think that's why, in general, my approach is to use first a GLP-1. And the second approach is to think that there are also, you know, we don't want to think about magically that you just take the GLP-1 and that's the solution. Okay, you need to monitor, you need to follow up with your patients. And again, if the GLP-1s you can't tolerate it and you have significant fibrosis, definitely you will need to try resmetirom. And again, as I said, if after 12 or 18 months you're still not fully improving, and again, the clinical trials show that a third of patients don't respond to a GLP-1 and probably 2/3 don't respond with an improvement in fibrosis, that's another point where I would add resmetirom to that picture.
Okay, I think that's very helpful for us. And I do want to point out to our patient community, because very often we feel like patients with MASLD, MASH, and type 2 diabetes, obesity, and all the comorbidities are being singled out. this is a systemic issue with healthcare in the United States, and there's different models of healthcare around the world. But this is the context we're dealing with. So it is a broader systemic issue rather than a disease-specific health issue.
Yeah, definitely. It's a big, and I'm gonna answer. And I see that we only have 12 minutes, and I don't want to leave the people without answers here.
Yeah.
So one person said, "What if I cannot see a nutritionist? What diet should I do?" Well, to be honest, you don't need to do any special diet. The person with diabetes, the person with a have to do basically the same diet, what we call a Mediterranean diet and low caloric diet with moderate negative balance. Because if you starve yourself, you're going to get hungry and rebound. Although intermittent fasting can work for some people, long term, it's just best to choose a diet that has more vegetables, fruits, healthy fat, nuts, fish, poultry to some extent, and avoid, junk food, to put in a few words. So you don't need to do a special diet, healthy diet, and moderate physical activity. There's a question here about statins. Have the statins been tested to reduce endotoxemia? Some thinking is that in obesity you have more toxins coming from your gut, but statins have been safe. So continue taking your statins will be safe in the vast majority, unless your liver enzymes are very, very high, 3 or 4 times above normal. And they do help hepatocyte function. So yes, GLP-1s have been tested in people with Swiss cirrhosis in a small study and for a year. We don't think that they are harmful. We don't know if it reverses cirrhosis. That's why we cannot recommend it as a therapy. Another question, Mary Jo asks, are you using Resdrifa along with GLP-1 if you started treatment with Idrissa and found it effective? Well, I mean, again, depends on your definition of effective. I mean, in general, you would have one stage improvement with either a GLP-1 or Resdrifa, rarely two. So if you're still going from early cirrhosis to F3, you may consider additional GLP-1 therapy. But probably your GLP-1 therapy is a broader question. I mean, because it has an indication for overweight with cardiometabolic risk factors, of course, for obesity, for chronic kidney disease and diabetes, for heart failure, so many others. And you may want to ask yourself if that GLP-1 would help for that. Georgia asks, which GLP-1 do you recommend? What about products like Kind? Oh, I see. I thought it was working for me at first, but now through I don't feel the patch is working. Well, I think that based on the evidence, the only GLP-1 that has phase 3 data in MASH is semaglutide. There is a good phase 2 study, means a study in not such a large number of people, with tirzepatide. Again, there are small studies with liraglutide and dulaglutide with the other GLP-1s. So if your insurance doesn't cover semaglutide or tirzepatide, just choose any GLP-1 that you can get from your insurance, and any weight loss will be beneficial. Again, there is some evidence that GLP-1s might do some things beyond weight loss, but weight loss is a large component of its efficacy. So anything you can get a hold of, okay? Let's see. Jennifer says, in my experience, it has been very difficult to get prior authorizations approved for resmetirom, but my GLP-1 has been easily approved. I'm going 2.5 months. Well, I mean, we have a very fragmented healthcare system. And again, both companies that make either semaglutide or resmetirom have patient assistance programs. So go to their websites and see what you can get, okay? Then APPs have an important role in, Lisa says, APPs have an important role in lifestyle concept, may be able to see patients more frequently. Yes, and again, I would encourage, if your hepatologist doesn't have time to talk more about you and train you on using giving yourself the resmetirom or semaglutide, talk with your nurse practitioner that are so effective in doing so. Another question from Lisa is, do you recommend that we stress importance of strength training? Well, strength training in people who take GLP-1s is really important because one of the big issues is that, and again, this is a great question, is people who take the GLP-1s may lose weight very rapidly, not only because they lose fat, but they lose muscle mass. They don't eat at all and they lose muscle mass. So rapid weight loss is not desirable. It also promotes cholecystitis and gallstones. So we want a moderate weight loss and we want to encourage them to eat protein, at least say 1 gram per kilo. And exercise makes you retain muscle mass. So that, and it also will also help burn more fat. So yes, exercise and a good protein intake are important. Mary Jo, okay, and any even with healthcare insurance, some GLP-1s are still expensive. Are there opportunities for clinical trials that can help? Yeah, there are a lot of GLP-1 trials with dual and triple agonists. Dual agonist means that in addition to just the GLP-1, GLP-1 is a hormone made by the L cells in our intestine or gut. There are others that add glucagon agonist. Glucagon is a hormone that does many things, but in the specific sense of mass, one hypothesis that it helps burn the fat in the liver. There's also triple agonist, one that not only adds GLP-1 or glucagon, but adds GIP, which is a hormone that we think helps improve fat metabolism. So there's a lot of trials. If you check with your hospital, your academic center nearby, or your area, you're going to find good clinical trials, and you would help advance the field. Again, talking about Gabrielle, talking about barriers, access to healthcare insurance card for a GLP-1 is an issue. I work for a Hispanic minority with high incidence of type 2 diabetes and obesity. I find it easier to access through spas instead of healthcare providers, but not follow-up labs or fiber scans. However, there's a benefit of that loophole. Okay, yes, I'm not aware of that, but again, it's unfair that many healthcare providers in areas with low socioeconomic status can access that. That's why you should try, if not, SGLT2 inhibitors can help, and pioglitazone has shown to reduce steatohepatitis about 50% of the patients and even fibrosis. So that would be a low generic approach. One thanks us for stressing exercise, very important. And again, what is your opinion on peptides to improve steatotic livers? There are no oral peptides that improve the liver, to be honest. So what I've shared is what the evidence is overall. Well, we have 4 minutes, Neeraj. Shall we show the last 2 slides, or there's a lot of questions. We could stay for another hour if you wish.
So what I think is important is I'd love to see how this conversation changes in 6 months' time, given the rate at which things have been developing. So we will schedule a follow-up.
You're inviting me back. Okay.
Absolutely.
I did a good job. I'm so
I-
grateful. Thank
I
you.
think you'll be back by popular demand, and we'll also bring in some of the other medical specialties so we can have that very transdisciplinary type of conversation. But I think at this point it would be good for us, Tiffany, if you pull up the slides, we'll go through our wrap-up points and just bring everything together. But I do want to stress one important thing, which was that in other disease efforts, the moment we got a medical intervention or therapeutic, we thought that was the end of the story. But that is one component in a comprehensive care package for patients. And I think that's always important to bear in mind. So it's not about a single intervention, be it a drug or exercise or diet or something, but it's how we have that comprehensive care package for our patients.
I
So
would
Ken,
say
do
it's
you
the
want to?
beginning of a new journey when we have a new drug and see how we add it to what we are already doing. So
Absolutely.
I think it's critical because up to now we only had, weight loss medications and diabetes medications, but that's changing. So I want to leave you with 4 messages. People with cardiometabolic risk factors, particularly type 2 diabetes and obesity, are those who should be risk stratified. Don't just start a GLP-1. Try to know where is that person at. I mean, because they may have cirrhosis and not know it. So very important to know if you have at risk between parentheses of cirrhosis MASH. Second point is that they will benefit from lifestyle changes, GLP-1s for obesity and for their diabetes, type 2 diabetes, and pioglitazone. Again, pioglitazone, people don't like it because it doesn't have a company that helps it get out. And they're thinking about this weight gain that can happen of 1, 2, 3 kilos. But in the background of GLP-1s, you continue to lose a lot of weight, even on the background of SGLT2 inhibitors. So weight gain is really not an important issue. Third, I think we talked extensively about semaglutide and resmetirom. We have two tools that we didn't have 2 years ago. So talk to your doctor about them. They can help you. And we're going to learn much more, as Neeraj says, combining them with good clinical trials. If you add resmetirom to a chronic use of GLP-1, you still get a good additive effect, and probably vice versa. But we need more studies. Last bullet here is referral to the liver specialist, to the hepatologist or gastroenterologist within a multidisciplinary team that has not only the primary care, but the hepatologist, perhaps a nutritionist, an endocrinologist if they need additional help. Have you considered metabolic surgery? Because within this, you're going to get the best risk stratification and know what the new treatments are. And again, the more you work with your doctor, the better off you are. And again, if you started a GLP-1 or resmetirom, you had side effects, let them know. Many times patients come many months later, oh, I stopped taking it because I didn't feel good. And it was something else. So stay in touch with the doctor, with your PA, your primary team, your liver doctor. It's a teamwork. And again, success, as you might have heard, is not a destination, it's a journey. And never more true than we're treating and managing people with liver disease.
That was beautifully summarized, and I think your last point was poetic. It is definitely a journey that we share together. And let me point all our viewers to a couple of points. One, the video recording of this will be on our YouTube channel. There's also a ton of resources on the Wellness League, which the Fatty Liver Foundation coordinates. That contains a lot of information around the areas that we spoke about. As always, we're grateful for our sponsor for the webinar series, Madrigal Pharmaceuticals. Ken, an absolute pleasure. We will do this again, I promise, and look forward to meeting you in person. And thank you all the participants.
Thank you for having this privilege and a wonderful audience with a lot of great questions. I hope it was helpful, and see you all soon.
Take care, everyone.
Take care, Neeraj.
Cheers. Bye.